All right, let's go ahead and get started. We want to try to finish up on time in the interest of everybody's schedules. So welcome. Thanks everybody for coming for our second meeting. And we have a long agenda. So I would like to go around the room again, and for those that weren't here or those that don't remember, do some more introductions. So I'll start to.
And before, I could just hear a loud voice for people on the phone. They hear from the microphones above, so quiet voices does not carry very well. So please, thank you.
Chris Peterson, HSCRC. Daniel, HSCRC.
Scott Rose, Shepherd Pratt.
For the MCS. Patrick Gully, you're with Maryland Medical System.
Bob Atlas, Maryland Hospital Association.
Scott Berkowitz, Johns Hopkins.
Colleen George, MedCat.
And Cam OKK, Medical Links.
Stacia Cohen, Care First.
Kathy Chapman and Associates out of Allegheny County. And I will add that we are also a practice as a member of Maryland. So we're a recipient of all your decisions.
Ben Stephan, Maryland Healthcare Commission.
David Sharp, Maryland Healthcare Commission. Mike Reedman, family practitioner and co-chair of the committee, and president of Maryland Primary Care Physicians. I want to make some issues with our video last time. I want to make sure we don't miss anybody on the video. I don't know if you guys called in yet.
So we have 20 people on the phone. The council members that are on the phone are Michael Barr, Kevin Hayes, Dr. Pham. I don't know, Mr. Schrader, are you on the phone? Dennis? I don't know if you talk about, and Joe Weidner.
Okay.
With 24, but 4 to 5 council members.
And if those that are on video have any issues, hopefully you have one of the cell phone contacts that you can call in, so hopefully we'll have that issue this time. All right, thank you everybody again for coming. And remarks from the secretary.
We don't have anyone.
So
We don't have anyone.
okay. So if they show up, we'll move back to the second agenda item with the secretary, one of his representatives shows up. Otherwise, we'll move right into the MDPCP program. And Dr. Haft, presentation for us.
Okay, thank you.
Over here.
Yep. Thank you, co-chairs. Appreciate that. So if you could do it for me. Hit the next slide. Just want to go through quickly some updates and level set again. I'm looking forward to, as always, a good and interesting conversation with the advisory council. The next slide. Just to re-level set again, this is a very important advisory council. It was established by the secretary. Apologize, the secretary is not here.
I didn't know that was. I didn't know what their agenda was. So.
Can you mute me now?
He may show up late, but he's often called to Annapolis at the last minute, so we give him dispensation for those things. But council was conceived and established by the secretary to provide advice to both the PMO and to the secretary on matters related to MDPCP. We're very fortunate to have MHCC who provides staff for the council, and the MDH is the co-manager of the Maryland Primary Care Program. And so I was just treading water until the secretary came in. I'd like to welcome Secretary Neal.
Hey. So we have a place for you up the front table.
I didn't have very good traffic light karma between 201 West Preston Street and here. Got a lot of Christmas colors and they were mostly red.
Well, thank you for joining us today.
Pleasure to be here. Would have missed it.
So Howard, since you just got started, we want to go double back and we'll let the secretary give us comments, or, okay, why don't we do that? Secretary, I'm Dr. Mike Reedman, I'm a family practitioner, we've met before, and co-chair the committee, so welcome, thank you.
Thank you.
And I'll throw the floor over to you.
Pleasure to be here. First, I want to thank everybody for what they're doing, because it's a big job and it takes a lot of people to pull it off. I want to make just a couple of points. One is I've never been in love with the nomenclature total cost of care, because the first thing that happens is that you sit there and think, okay, who's getting their goose cooked, because you're controlling cost. And I prefer the Maryland model, which would take advantage of all of our unique strengths in our all-payer system and all of the great providers and physicians and other healthcare professionals to try to give the people of Maryland the best healthcare possible. To me, this is a once-in-a-lifetime opportunity to modify the way things are doing. And one of the measures, and it's not in any of our documents, but it's just one that I have in my own little mind, is that I think we will know we've succeeded if the people we serve, the patients, see a demonstrable change in their, for lack of a better word, customer experience. I listen very carefully to people. Now that I'm health secretary, and they talk about these things, and lack of time with their physician, and the time that they do have, they're usually typing and not making eye contact, and there's a lot of waiting. And so I just hope that we remain mindful that we got 6 million Marylanders who are looking for us to do the best job we can. One of the things that I'm trying to do as health secretary is I want to align our public health assets in the department to align with this effort. And Fran Phillips is doing a good job doing just that. The other thing that I'm really interested in doing is trying to build a network of community services and programs in virtually every community in the state that are agnostic to insurance coverage. So if your doctor thinks you need to lose a little weight, or you need a little nutritional counseling, or an exercise program, he or she can refer you to that community-based program, and it should be either free or dirt cheap and convenient. I'm also going to spend a lot of time talking to employers, because most of us spend at least 8 hours a day doing our work, and I think there's a way that we can work with employers to provide a healthier atmosphere, opportunities for exercise. I stole a room on the first floor, the lobby of the health department building, and put in a gym, which is being used, and happily so. Healthier dietary choices, and I'd love to be able to. Most of the big employers, including the state government, the county governments, the school systems, and a lot of the big private sector folks are self-insured. So they pay every dollar of the healthcare spend. And I'd like to be able to get in front of as many of them as I could and said, you know, if you work with us, we may be able to reduce your healthcare spend if you do 1, 2, 3, 4 little things. And I'd like to be able to socialize that throughout the state. It's going to require some time, but the one thing, there are 2 things. One thing I learned from my work with Governor Schaefer was that time is not your friend. Time is your enemy. The sand falls out of the hourglass. Another thing that I've learned by spending a career trying to change or improve troubled organizations is that it requires a certain amount of momentum. And if you can initiate some momentum and maintain it, you can get the work done. If you start to get mired down, or even worse, thrown for a couple of losses, you lose the momentum and then you lose the ability to effectuate change. So those are the things that are really frontmost in my mind as we proceed through this. But I'm optimistic. I'm excited about the prospects of being able to do this. And if we do it right, I think BWI Airport will get a lot more traffic because people will be coming to Maryland trying to figure out what the hell we're doing here. And I think that would be kind of a treat. I'll be happy to answer some easy questions if you have any. I'll refer to Dr. Haft or some of the other experts. I know just enough about health to be dangerous. There's some real experts in this room, so I'll be happy to try to answer them. Some easy ones. Yeah.
So, Mr. Secretary, there may be more questions as we go along. Are you able to stay for a while? Or?
Well, it's budget season, and I've got to go back. We're doing a dress rehearsal in which I'm taking groveling 101. We've got a big day with the Department of Budget and Management tomorrow. But I did, between groveling rehearsals, I did want to come over here and say hi to everybody. And thank you for what you're doing. Thank you for participating in this group. And I see an awful lot of familiar faces around the room that I see in a number of different venues doing great work.
Well, thank you, Mr. Secretary. Are there, Melanie, anyone on the line that has a question for Mr. Secretary? Some of our members are remote today.
We have some.
We don't have
Barron's
anything.
here now as well.
Dr. Barron's, yes. For the members. And Deborah Kushka-Craig is also joining us today as a member as well. Thank you. Dr. Reed.
Yeah, if not, no more questions, we'll turn it over to Dr. Haft if you want to stay for a few minutes or so.
Yeah, you know, I've seen his act before, but I'll hang it up.
Thank you, Mr. Secretary. I think we left off by stumbling through the words that the MDPCP is managed jointly by the Maryland Department of Health and the Center for Medicaid Innovation, and the Program Management Office is responsible under the Secretary for carrying on the management. We'll go on to the next slide. Just some updates for those, since we have a relatively short interval, just things that have happened in the last month or 6 weeks. We had a little prognostication of what the new year looks like based on the best available information that we have, which is not final until probably another few days. But it appears that by 2020, January, that every major health system in Maryland will be participating as a CTO. By 2020, somewhere around 480 practices. Again, the number is not final, but very close to 480, a little above, perhaps, will be participating in MDPCP, which is about 2/3 of the eligible primary care practices in the state. Care transformation organizations are in every county in the state. In July, mid-year, we had about 213,000 beneficiaries attributed to the program. And by 2020, that number will likely range over 300,000. We had 30,000 dual eligibles, and by 2020, that number will likely be over 40,000. As a reminder, the program, the transformation that is done for the practices is done not only for the fee-for-service beneficiaries, but the practices are required to transform their practices for all patients in the practice. So effectively, we'll be serving over 2.5 million Marylanders every day by 2020. And notably, by the end of this year now, we'll have 220 practices that have integrated behavioral health and over 140 that have formal processes in place for identifying individuals with substance use and putting them into brief interventions and then referring them when necessary for treatment. Last bullet on this page is PQI reduction. I've been cautioned not to be overly enthusiastic about that. So I'll say that PQIs are really the measure that we use for how we can identify ambulatory sensitive conditions that are better cared for primary care offices or in ambulatory settings than in the hospital. We actually do have objective measures for those. We don't have a measure when one doesn't happen. You can't measure something that doesn't happen. You can only measure what does happen. What does happen in terms of those in Maryland is somewhere north of $1.5 billion a year, and things that could be better taken care of in an ambulatory setting. So we don't know how to monetize the reductions in that, but we do know that a positive trend showing a reduction overall over time in avoidable utilization is definitely a good thing. It's hard to monetize because we don't know how to monetize reductions in utilization, period. There's no direct correlation between that and reductions in global budgets, but we do know it's a good thing. And at the heart of the program, at the heart of the concept behind this entire program is that primary care practices will have investments. They will use all those investments to improve health, as the Secretary has compelled us to do. But the measure of how we will be able to shrink the entire budget for healthcare is by taking unnecessary care out of high-cost hospital and ED venues where it's not necessary, and reducing the investments there, and putting more investments into primary care. So I think we'll talk about probably later on how return on investments are characterized anyway, but I think that's the fundamentals of that. Some additional, I'm not done. Yeah. You'll have, I'm sure you will chime in.
Sure, I don't think the number's right.
Well, that was your number. I took that out of HSCRC.
So can we come back to questions? Because I think we want your questions at the very end of the presentation. That works.
Sure, that's fine. Well, whole practices and MDPCP are now connected to state-designated HIE CRISP. All practices receive monthly updates on their attributed patients, utilization, healthcare costs, and resources on the dashboard. So this is something unique for the state, and probably fairly unique for this kind of program, that every practice gets a harmonized set of data. Some of the commercial plans have done that before also. We've added to that program, and I think since our last meeting, also an addition, which is a tool which predicts which patients are likely to have avoidable hospital or ED events within the next 30, 60, 90 days. Tool that was created by our colleagues at the Hilltop Institute at UMBC. So far is proving to both be user-friendly in terms of workflows and effective. It's very early, it's only been the first few months, but tool that we're provided again across the board for all practices. MDPC practices have implemented care alerts. I'm happy to say care alerts didn't really exist to any extent in the continuum of care before this. As most recent, more than 20,000 care alerts in the system. So it's been a very, very rapid, I'm happy to say, uptake. Care alerts are an important part of way of providing continuum of care information across the, no matter where someone shows up, hospital, ED, or other places. Patients are routinely being screened for the social determinants of health, and we've established, together with our great partners at CRISP, a bi-directional system so that when a patient who has a social need has been identified, they can now refer to certain within their regions and to certain agreeable community-based organizations, direct referrals that are bi-directional and share information back and forth between the practice, the care manager, and the community-based organizations. For instance, Meals on Wheels for some diabetes prevention programs, diabetes self-management programs. We've also established a relationship and anticipate somewhere in the late first quarter, early second quarter, that the Maryland Department of Housing and Community Development will also be on that framework. So individuals who've been identified who have housing needs, who need ramps or ramp rails, or have housing insecurity, can get directly referred to our housing and community development enterprise and also Catholic charities. So We've also submitted a proposal to CMMI for allowing federally qualified healthcare centers to participate in the program beginning in 2021. And we're working with our partners in Medicaid and CMMI along the lines of chronic health homes admission also. Those are both things to happen in the future. Next slide. So in terms of timelines, and I think this may be relevant to the discussions here, we've had some discussions with our partners at CMMI who are also in the audience in terms of things that can and can't be done within certain timelines given the clearance processes and the ability to accomplish multiple tasks at the same time in a complex environment. We are hopeful that in 2020 that the RFA for FQHCs will be available, so they would be able to enter as early as 2021. Again, this is tentative. It's not, nothing here is certain until many other things happen. We hope that we can offer a suggestion to the advisory committee in 20 that one of the pieces of work that can be done here is taking a careful look at the primary care spend in the state, the overall primary care spend in the state, as it compares to benchmarks or other states, and how it fits into what's happening nationally in terms of primary care spend. There would be, I think, excellent focus for this advisory council. I think that in 2020, and I think this has been discussed also, that we anticipate that there will be a great deal of discussion, deliberation, and analysis on how best to establish future payment tracks, or track 3, or altering the comprehensive primary care payments, other kinds of things that would be in the future of the MDPCP. I think as Will has stated, it was never contemplated as a static program. There are things that need to come out of it, things that need to be added into it. That I think would be probably in the time frame it will take a good deal of deliberation to come up with what would be something that we could model and say makes sense for this program in this state in this unique circumstance. And hopefully that could be something that would be available again for 2021 RFA. Discussions with Medicaid about their inclusion again, possibly for 2021 RFA. 2021 would be the earliest start date for FQHCs. It could be 2021 an RFA that might include a track 3 or other modifications. Medicaid is an aligned payer, and possibly chronic health homes. And then in 2022, the earliest track 3 inclusions, earliest Medicaid inclusions, and the earliest chronic health home inclusions. So those are, I think, work for the next 3 years, which will keep everyone fully engaged. And then the last slide is a little update at the beginning of the year, but I think we'll color the whole state red. It's not a political statement. It's slowly the size of the bubbles. Now, happy to entertain questions.
I know Will has a question, just for procedural purposes. Remember, the best way to get your question answered is just to hold your card up and put it up in front of you, and then we'll call you. Hopefully, you have a question. I'm calling you, but I know, Will, you had a question.
Yeah, I guess less a comment, or more less a question, more of a comment. The PQI reductions, we run a PQI program with penalized hospitals for, excuse me? Louder. I have to work up. So we run a PQI program. We penalize hospitals when they have a potentially avoidable admission. We'd obviously like to make sure that the numbers reported by the primary care program match the numbers that are reported in the PQI program, because there's a lot of payments that are associated with them for hospitals, and we're not quite sure, I think, where that number came from. So
It came from your PQI.
Right. Well, our experts would have, I think, noticed a 21% reduction. So maybe
This was for the MDPCP attributed patients. But again, this is, I comment on that as a positive trend.
Right.
I totally agree that there's a lot of work that needs to be done in terms of how to quantify that best, but the trend was a downward trend for the MDPCP attributed patients in your report. I'm happy to call it up. 20% reduction. We don't have a PQI.
So we don't have that report either.
I can get it for you. I don't want to argue with you, but I can put it, have you put it up.
Any other, I'll let you guys figure
Yeah, we could do that
all
offline.
that.
I'll try to do that.
I
One
see.
other question is I just want to go back to the timing for a track 3. So are you saying that there could be 4 2021 RFA for track 3? And I guess
So actually what I hope to say is to echo what we discussed with our colleagues at CMMI, that we would want to look for volunteers from the council or others to establish a work group to work with CMMI, the PMO, the state, to deliberate on what would be possible, what would make sense, what would look like reasonable modifications in the current payment systems that could appear as early as 2021 in the RFA, be available for 2022.
And my only question it's not going to be feasible to do something soon enough that is as substantial as a track 3 to have that operational in 2021 unless you were to do that in the next couple months. So you're really looking at the RFA coming out in 21 or 22.
Yes.
Gotcha.
Any questions online?
I don't right now.
And can I just interject for a second? I think the question on the PQI is important, and maybe what we can do is we can look to figure out what the data suggested would be, and we can bring that back at a subsequent meeting, perhaps at the next meeting or in between. We can share information as we've determined it to be based on it may give some more reasonableness to the trend line if that works for Chris or Will or Katie.
So I just wanted to just chime in and want to thank Howard. I think should be looking at PQIs and avoidable utilization and the impact that the practices have and the other supports that the practices can give their patients to help reduce that. I think it's also really important to make sure that we're on the same page about defining the PQIs. We currently don't use ED PQIs, but certainly if the PMO or the primary care practice wants to include that. So I think just the word of caution that I was entering is just that we should just continue to be on the same page. And I think it also gets to the need for good data, and Chris is a great source of data for us, but we need to continue to use that as we develop what the targets are for the PQI reductions and how we can make sure that it's reflected in hospital budgets, as Will mentioned. So I think it's something that we can work together on, but we just have to make sure that we are on the same page in terms of what the definitions are, making sure that we're comparing apples to apples.
Yeah.
Great point.
Yeah, totally agree. I think the fundamental issue is that's what we're after. We're all after reducing unnecessary utilization.
Jane, you got a question?
Hi, this is Mike. Can I ask regarding the timeline and I guess a couple of things. One, I'm just a little confused about whether there is an intent to eventually include other payers beyond Medicaid. And the second is track 3, am I correct? The assumption is that FQHCs would not be eligible for track 3 on the assumption that it actually involves a payment structure, and we're not talking in this model as disrupting their cost-based reimbursement, or are we?
I can answer some of those. In terms of FQHCs, there's still a deliberation going on in terms of whether or not they would be able to qualify to enter the program. As you know, they were not permitted to enter into CPC Plus or CPC Classic. They are permitted to enter into patient primary care first programs. However, the issue probably will be, as you're aware, fundamentally around PPS and the interface between PPS and the way the payments are made, and particularly in track 2 of this program. But that is currently I think in consideration within the HHS and the CMS. So that, no answer for that. In terms of FQHCs, the earliest they would be in in 21. In terms of other payers, there is the RFA for this year did allow other payers to submit proposals for participation. And I anticipate that the RFA in subsequent years will continue that opportunity. We don't know what the RFA is, but I see no reason why limit that.
Yeah, Mr. Secretary, do you have any comments to add at this stage?
Just that, could you put the slide up that shows the map of Maryland with the globs of red? If you look at my beloved Eastern Shore, it looks kind of sparse there. And one of the reasons I'm very interested in getting the FQHCs involved is they're major providers. If the FQHCs on the midshore and the lower shore were in, that map would look a lot different. And so would the area around Hagerstown. So I think that's essential, because I don't think that map looks so good.
Yeah, that's a good point. Thank you, Mr. Secretary.
Could I say one other thing? You ought to go to the public health part of our website and look at our diabetes plan. A lot of people worked real hard this summer, and I think they did some great work. And it ties in with the alignment I'm trying to reach with the public health administration and this whole project. And we announced it last week in front of the American Diabetes Association. Happened to be, we hijacked a portion of their meeting, and it was very well received. I think there's some great elements in it that I think will work to our mutual advantage. Thank you.
Thank you, Mr. Secretary. Ben, you had a question?
So, Howard, I just thought maybe you ought to say a little bit more about the AI predictive analysis. I know that most people can't see the dashboard, but it does have enormous level of precision. And I just was going to wonder if it would be better to have an ordinal values, say lowest to highest by numeric ranges. But I wondered what were practices making of a patient having a 97.2% probability of a potentially avoidable hospitalization. What's the feedback been on that? Would a more less precise measure be as good without sort of directing patient practices too finely? I better deal with the patient that has a 97.3 as opposed to a 95.1 level of probability.
Thank you, Ben. That's a great point. And actually, the original, we worked with our stakeholders in this serial fashion on the user interface for that. So the original user interface was simply color-coded so that you could see the top 1%, the top 5%, the top 10%, the top 20%. It stopped at 20%. But stakeholders said they wanted to see the actual number within that. So it's both color-coded so that you can just discriminate. Here's my top 1%. Here's my top 5%. Here's my top 10 to 20%. And also the numbers. How many decimal points? We argued how many decimal points to carry out. I said, I don't know how many decimal points. Nobody gives it. Nobody cares about that. But thank you for that.
I can add to that also. The way the practices also use that tool is, that the HCC risk stratification comes out in quarter. So for those who are already in longitudinal care management or long-term care management, what the care managers use that tool to do is look at it every week or every month, when it's released, and kind of compare with what they're currently doing and see if there's any difference or provides more insight as to new patients that have gone into that high-risk bracket or those who have kind of fallen out. So that's another practical way that monthly update helps.
Yeah, if there's evidence that we can be that finely predicting this, that's great, but I wouldn't want to over predict when we don't have enough evidence that is accurate. But I was startled when I looked at it.
So the tool is used largely to identify those who are at high risk in our two-tier risk stratification. The workflow is that the care managers will download that on an Excel spreadsheet once a month, show it to the individual providers. The providers say, this is what I'd like to do about those patients who are the highest risk. And in the January release, we'll have also the ability to drill down. So for each individual patient, you can see what contributes to that risk, whether it's just got out of the nursing home, or whether they're on competing medications, or they're on anticoagulant, they haven't had an INR, or whatever the factor is, so that they have more ability to be specific about what interventions need to be done. So it's a pretty cool tool. And it's available. I think the coolest thing about it, it's available to thousands of providers across the state now in a uniform way.
In the interest of time, I'd like the cards that are up, except for Ben, let's finish up those questions and we'll move on with the agenda. So I think we'll start in corners round.
I'll be quick. I appreciate all the new tools that are available. Dr. Happ, I was just wondering if there was any update on the detailed CCLF-like claims data that the practices were expecting, back when we began, or what the timeline would be for the practices to receive that data. Working with CMS on that.
Yeah. So I still understand that it will be it was this winter, or maybe a little late. We're getting late in the winter, so probably first quarter.
It was spring, and then it was summer.
I know. I think it's promised. It's in the participation agreements. I'm sure it will come. I can't personally. That's not something that I know that they're working hard to get that out. And subject to complexities and contractors and others. I know it's important.
The performance of the program, I think that is a real missing piece. The practices to really be as effective as they can without that data. In the interim, we appreciate all the tools that we're looking at as we move forward. Thank you.
Thank you. In one of your earlier slides, I guess the one that precedes this one, you say 2/3 of practices will be participating by January, and 300,000 beneficiaries will be connected. So that's 2/3 of the practices, but less than 1/3 of the beneficiaries. So can you explain?
So I think, other than the fact that that's 2/3 of the eligible practices in the state, not all practices. It doesn't include probably some pediatric practices and others that are
Right, but those that are naturally served Medicare.
And so that's a number. What's a disconnect? I actually can't tell you and I can't tell you also whether 300,000 is exactly the right number. We haven't seen those figures. That's an estimate. It'll be based on what we know now. That'll go up about a third over what it is.
Just wonder if there's a barrier to getting patients connected. We're putting a lot of investment in to get this program, make the program successful. If it's only going to touch, at possibly, the peak enrollment of providers, if it's only going to touch about 30% of the beneficiaries, that's potentially concerning.
So we're not at peak enrollment. That's the good news. We have 3 more years of open enrollment. So there's opportunity for considerably more. It doesn't, we don't have the FQHCs in there. They are a significant number of beneficiaries. And there's also, this issue of kind of leakage, that there are patients who are cared for in the program in practices that are not counted as attributed beneficiaries. So probably underrepresents to some degree, and I can't tell you what degree, the total number of patient beneficiaries cared for. More importantly is that those practices care for with the information, with the changes in their care delivery for all of the patients. So the number of 2.5 million is probably more accurate representative of what's being cared for.
I'm just, if I may.
Ed may have some.
I just wanted to echo what Howard said. I think the attribution rules are pretty tough. And as there's greater awareness of what triggers affiliation or attribution with a practice, I think these numbers will go up, even though holding the practice is static. One of the things that I don't think Howard probably can add on this is the annual health visit is a trigger for attribution. And in the first year, because it was, you're looking backwards, that may not have been done by all primary care practices that treat Medicare. I know Hopkins did quite a bit of work on making sure that their community physician practices did that annual health visit.
So I'll just
Can I ask?
say, for the program to be as beneficial as we hope, I realize there are issues of how we define, what attribution means and how we can track. It would be, but if the numbers were greater, we wouldn't be looking for explanations. And so the point is, let's maybe put some energy into figuring out how to make sure that patients, beneficiaries feel the opportunity and the benefit of the program so that we can realize the impact that we're making this big investment to get. And then I just have a question, since I know on the agenda is this notion of establishing this payment work group. The topic of the work group came up, so is that still to be discussed?
Okay. We can have that conversation now. Part of our agenda, but well, actually, let me go through the questions here, and then let's go back to that because it is on the agenda, and I'd rather do that. So,
my question was real quick, and that is, I know that the tools and resources are being provided to the practice. Can you give a little bit of insight about how much they're actually using it? We know CRISP has been slow on the uptake in many ways. The prescription monitoring program has been slow on the uptake. And so I'm just curious about, the tools are only going to be as good as the people actually signing in and using them. So can you give us a sense of that?
Yes, and that's a great point. We monitor this weekly, so we weekly get a CRISP report on individuals who are using it, down to how many people have logged into the prevent avoidable hospitalization tools, how many people are doing ENS, how many people are doing care alerts. Again, the uptake has been dramatic. Way more than 20,000 care alerts in the first year. Virtually everybody in the program is on CRISP and has ENS, not 100%, but nearly 100%. We'll have by the beginning of the first quarter, 100% practices, or in the first quarter, 100% on ENS. So CRISP is central. Absolutely.
I don't think that's exactly what I know that most of them are registered. I was more trying to get at
getting
actual utilization of it.
So this is people going to their website, logging in. So I can't tell you if once they've logged in and downloaded their ENS, what they do with it. That's up to them.
Okay.
But we can tell that they've gone in, they've gotten the ENS. We can tell that they've logged in and they've looked at the pre-AH tool. We can tell every time that they log in. The uptake is very dramatic.
So is that 50% of the practices? Is that 100%? I'm just trying to gauge, are people actually using it?
I'll be happy to provide you with.
So I have some data right off the press.
Yeah, great.
So
Could I ask sorry, I thought you were done. I was going to ask a quick question about attribution when there's space.
Dr. Pham, I think it is. Let me, we got two more people with some cards up, and then.
So all but 13 practices had at least one user access to the MDPCP reports, so that's good. I think I'll leave it at that. I can't quickly summarize everything that's in there. But
no, that's helpful.
And we lose, and even with that number, it's not 100% because some large organizations will log in as an organization and then distribute reports to the individual practices.
I'm going to take these two questions and then Dr. Pham, and then let's wrap this portion up if we can. So.
Can I respond to her question? Sure. Okay. As one who lives the practice every day, it has not been without hiccups. I mean, we have had where we lose access, regain access, someone suddenly gets kicked out. Getting our patient reports sent has been problematic because you have to have a CRISP direct address, and we have not. Now, I don't know if you guys were just a little dropping back out in the movies, but it has not been without problems, and it's not for lack of trying. So,
And maybe Kathy, we can connect you with Craig Beam because he's actually in the audience. We can connect you with him after the meeting, and you could, while you're here, you might be able to have a conversation with him.
yeah, and I have been emailing Jeff.
And you had a question too?
I did have a question, and this is for Secretary Neal. I'm from Western Maryland, so I identify with your Eastern Maryland lack of healthcare access. One of my questions is, having worked at an FQHC in a rural environment, there seems to be a lot of duplicity through with Maryland PCP and FQHCs. They have a care manager that helps people get access to care and transportation. They have a pharmacy person who helps them get medications. They have the 340B program. So it seems like a lot of the things that Maryland PCP is encouraging for the private practices is already in place for the FQHC. How do you envision them becoming part of the Maryland PCP, enhancing those services without duplicity?
I think we're going to have to align things. FQHCs, by definition, are in underserved areas. And that's the reason they're there. That's the reason they get the federal grant, and that's why they get preferential drug pricing and everything else. You certainly don't want to sacrifice that capacity. I just think that we need to align it properly so that there isn't any duplication. I think it's just going to be a lot of just gut work trying to get that done and trying to figure out how to do it. But these areas need more access. And one of the things that I'm concerned about in passing the financial test with feds is that in my heart of hearts, we need to add some things before we start deducting. And I'd like to have some semblance of adequate access throughout the state before we start to get into our subtraction and cost saving exercise. And I think we need to do it first because these areas have been this way for a long time. And truthfully, I think that's where a good bit of your savings is going to happen, because people didn't have access to a primary care physician, usually ended up in the hospital one way or the other, through the emergency room or just through the admission process. And so those people need attention. But I ran a Medicaid MCO, and 8 of the FQHCs owned half of my company. So I'm not unfamiliar with the way they operate and what they bring to the table, and I think it's considerable.
Colleen, and then Dr. Pham, and then we'll finish up.
I just wanted to touch base a little bit on the CRISP tools, and number one, being out in the boonies, as you say, has no bearing at all on how CRISP feels about you and your access. And so if you're having access issues, certainly we want to solve those. And
I didn't mean to be slam on Chris.
no, I know. No, you sounded like you were slamming on you, and I wanted you to let you know that no slam on you at all, but that CRISP loves everybody equally. But I think the CRISP tools are valuable, and personally, and I apologize for this, that it's on a personal level because I've been so involved with the PDMP. I think the PDMP is really up and running really well and been very successful. And because of that, I think the rest of the CRISP tools are, if there's hiccups and if there's, a couple slow uptakes, I think part of it is on the part of the practices not utilizing them as much as they can. And
That was my point.
Yeah.
Right, just trying to understand.
And if there are any issues with CRISP, you can certainly reach out to Craig, but you can reach out to me as well. And we will always try to solve any CRISP issues that come up, whether they're access issues or how to use them or how best to use them, those kinds of things. So I just wanted to, speak on Craig's behalf because he's sitting in the audience and should probably be up here instead of me.
Let me also add to that, work that has been done, at least from the payer side with Medicaid MCOs in partnership with FQHCs, we can get some insight from what has been happening for the past 5 years in this primary care collaborative we have going with the FQHCs. And I think the first, and this was on the leadership of Bob Neal, but Secretary Neal, but one thing we thought to do first was, just like the MDPCP, have the leadership in the FQHC or in the practice determine what resources they need. So, and as you know, with the CMF payments, all the different buckets of payments, as long as you're within the guidelines of spending that money, nobody is forcing your hand to do this or that. So same thing with those MOUs. So you're right, there was a lot of duplicity. So we kind of left that to leadership to say, let's have an idea of additional payments based on your attribution. And if we give you this, we hope that you can use it to solve whatever problems. If you don't need pharmacy, you don't need more care managers, maybe you need community health support workers. So you make that determination, and that kind of takes care of the duplicity and really help you spend the money wisely and get the outcomes you're looking for.
Dr. Pham, and then we'll move on the agenda. You had a question, Dr. Pham?
Yeah, I guess it was triggered at a couple of points. One, the question on attribution that came up with the predictive analytics, and then I think thinking ahead to the future of the program. Have there been conversations with CMS about the possibility of allowing patients to select their PCP practice ahead of time, and in addition having those selections carry over to subsequent years in the absence of the beneficiary saying, now I want to change my PCP? I ask because I think it could kill several birds for both the practices and the program. I think it would build stability in the relationships, both from an analytic view, but also I think get that beneficiary engagement in the work that's to be done. It gives the practices a lot more predictability in terms of what they can expect in both patient engagement and patient volume from year to year. So I'm just curious whether that conversation's been had, because CMS has the capacity.
Well, I'm sorry.
I was just going to answer that.
Okay.
So yeah, the answer is yes. The conversation has been had from the beginning of the program, and there were technical issues. I think initially in doing self-directed attribution, but I see now that in the newer programs that are coming out of CMMI, it seems to be actually a preferential way of doing attribution, and I anticipate we'll, with the support of the advisory council, that we'll continue those discussions, because I agree with you completely. It's a very, very good way to enhance attribution.
Yeah, I want to encourage you to not let CMS off the hook. I built that capacity for CMS. I know they have it.
I would just be careful about it. We've been doing prospective attribution for our PCMH program for 9 years, and oftentimes beneficiaries don't go to the clinic that they identified as their clinic, and then the clinics are bad. So it's 6 of one, half a dozen of the other. There's no perfect attribution model.
There is, amen, there is no perfect attribution. We'll agree to that.
All right, well, thanks everybody for the comments, and thank you, Howard, for that. We have on our agenda the a review of some of the comments we made last time, but I think in the interest of time, unless someone has a specific comment about our discussion, I'd like to move on to the other agenda items. And before I do that, I'd also like to, I know we have some members of the public, and I don't know if we're going to have time today. I certainly want to try to make the effort at future meetings to have some public comments. We will be supplying some communication for you to be able to comment after the meeting too by email. So just keep that in mind as we go through. Again, if we do have a little bit of extra time, we'll open that up. It's already come up a little bit already about the establishment of a work group on payment design, and I personally, and Howard and I talked about, or had a little bit brief interaction on this. My concern about the subgroup is that I don't want to dilute the input from this committee, and I think that that's critical in sort of the work of this advisory committee. But some of the work may have to be done at some point by a subgroup. So I know Howard had some thoughts on it, and I'd like to really open up the group for a conversation about what they feel about a subcommittee, whether this is the appropriate time, whether we should have a subcommittee, and then we'll go from there. So you had a couple comments.
Yeah, so in discussion with CMMI, because there are some, from their perspective, there's some technical things that they can and can't do within terms of payment design. Rather than have the advisory council labor on a design that is not able to be implemented or implemented in a reasonable time fashion, that their feeling was, and I don't disagree with it, that having volunteers from the advisory council, as many as would be appropriate, including some of the participants in the primary care program, meeting with the PMO and CMMI in a joint session, developing those models so that they can both be vetted in terms of what's reasonable from the program's perspective, what the stakeholders feel is appropriate, and at the same time what is achievable within the ability, knowing that CMMI ultimately has to have, they and their payment contractor need to make adjustments and payments to whatever the new payment scheme would be. Something that doesn't fit into a current scheme, it could take much longer if it's better into a current scheme. So their input, joint input, seems to me to be a reasonable way to go. But, the advisory council is free to develop advice it wants, and then ultimately the advice that the council gives will be vetted under the same common pathway for everything. The advice will be vetted to the PMO and to the secretary, and the secretary will make a recommendation to CMMI. So it might be good to have CMMI involved early on, and have the advisory council involved early on, so that the product will be more likely to be acceptable.
So if I could just weigh in to the comment Michael made and to Howard, I think that there is going to be need for breakout groups at some point, and we can call them work groups, we can call them subgroups. But I think that the decision around doing that depends largely on the information you all bring forward. For instance, at the last meeting in October, we began talking about increasing accountability to institute tracks. And we didn't finish that conversation. We heard some concerns from some of the members regarding the pace at which to do that. When should practices be required to go to track 2? When should there be a track 3? So we've heard some conversation around that. So it may be a bit premature to decide whether or not at this stage we need a subgroup or work group, but allow the advisory council to continue having the conversations and let you all decide when is the trigger point and whether or not we reach a trigger point that a subgroup is required. And we can engage CMMI in these kinds of conversations over here if that's open and transparent enough for everyone, as opposed to having more of these one-off conversations. It keeps the continuity of thinking around the high-end thinkers we have at the table. So I would pause there and then invite people to respond. I think Patrick is that you.
Yeah, I was just gonna say, I think it depends on the level of depth you want to go into on the conversation around payment design. Just because these are 2-hour meetings every other month, and so given the agenda and everything else, we're only ever going to have a very finite period of time to do any real design work. Call it that, versus kind of giving maybe not governance is the right term, but high level kind of strategic advice back to a group that's kind of in the weeds more so on it. So I actually would be in favor of keeping the discussion maybe at both levels. One is just more of a in the weeds type mix on really design type issues, and the other is more of a strategic guidance of where we want the program to go and high level things that we see. Because just looking at the kind of folks around the table, I'll just speak for myself. I'm not in the day-to-day every single time on what is going on and kind of goofy things that may happen because of this rule or that rule. Whereas I would want some of those people maybe involved on the design parts of it, because I think they can be helpful and more informative. So I think it may not be, in my mind, it's not taking the responsibility away from the advisory council to provide that type of feedback. It's kind of the level of feedback on which we are interacting, versus we need to really get into the weeds with CMMI and Howard's team and others to figure out what that track 3 team would look like.
So I think I'm pretty sure I agree with Patrick on all of this. At our first meeting, we were handed here's a track 3. What do you think? As if it's going to happen real soon. And now we're seeing this timeline that says we're going to spend 2020 studying the possibility of a track 3, may be included in doing RFA for it in 21, which I guess then says, started in 22. I'm not sure whether I like that slow process or not, given that, this is being evaluated as part of our total cost of care model, and by 2022, CMMI is largely going to have their mind made up of whether they like the whole Maryland model as currently constructed. And that doesn't mean I'm ready to decide whether track 3 or any other payment alternative would help improve the success of the model or hinder the success of the model. I definitely want to have that discussion. I think that, an appropriate process, I could, if I had the time, be, technically at the table and participate in that. I think what I'd rather do is have one of my staff do that in a kind of a technical work group. I definitely don't want to be presented with something that's done in a windowless room by others, and then just have to decide thumbs up or thumbs down at this table. So something that's a little bit of a deep dive by technical experts, but not like presenting complete binary yes or no decisions to this group. I think there's some smart, knowledgeable people. We're all, in one respect or another, we're stakeholders, so we have skin in the game in terms of what's implemented. So something that is more logical, sequential. It can be. I don't mind if it's faster in terms of at least getting to something to consider than what's on this slide.
Scott.
Yeah, I was going to echo the idea that depending on how in-depth one would want to go, and if you're going to build scenarios and modeling, it seems like it's beyond the scope of this group. But I think it's really important that it's interconnected. There's a reason why there's the constituencies that there are here. I think it would need to be married closely. And so if there's a standing update on the work group, this work group, as well as potentially other work groups, I would suggest that we probably should have that every meeting so that people don't feel like things are veering one direction or another. And I would also suggest that in terms of the constituency of what that group would look like, that it mirror that of this group, and whether it's technical people, maybe multiple people, being open to inclusiveness is probably worthwhile, especially because I think we all know from the conversation last time just had gotten started, and I think there's going to be a lot of potential thoughtful debate that will probably come up on those issues. Just want to make sure there's enough time and the right people are part of that conversation.
No, I mean, I would agree. I think probably there is merit to having a level of technical expertise, but I would think that it would be good for, as Joan suggested, there be a mirror of representatives around this table and led by maybe one of the co-chairs, because I think it is important. The advisory council should and probably should set up subgroups to do deep dives, but it should come back up to the advisory council and follow the path of recommendation to the secretary. And then CMMI can be involved or not involved, how they would like. We definitely have a path for communication with CMMI. I think they've expressed that they want to make sure it was state stakeholders. So I think it would be important for this group or a subgroup of this work group to make recommendations, bring it up to this advisory council for discussion, and then bring it on to the secretary and then eventually to CMMI.
Thank you. Robert, just briefly introduce yourself too.
Yeah, I'm Bob Berenson. This will be the first time I talk. This is my first meeting, so it's nice to see everybody. And I guess I've spent the last 2 decades of my life thinking about payment policy, payment methods, and the idea that you would just do that in the advisory committee, just not gonna happen. I strongly think you need a technical working group, and I'm all for having the working group have to report back at every meeting, but I just don't think you're gonna develop track 3 at these meetings.
So says 2 decades. He's trying to make himself seem younger.
Unfortunately, Atlas
He was a colleague of mine at least 25 years ago.
For those who don't, has my bio been distributed?
I tried to slip it in last month, but
Just the highlights are that I practiced general internal medicine. I was the head of payment policy at Medicare the last 3 years of the Clinton administration. I've been on MedPAC, I've been on PTAC, if anybody's heard of that.
I want to hear the whole insight on that one.
And so that's what I do.
And I was going to nominate him.
I was gonna say.
So I just wanted to sort of say that it was anticipated that this group would have offshoots of work groups, that there was the recognition that there would be technical work groups flowing off of this. I think that we spent a lot of time thinking about representatives, including twisting arms of national experts to join us. And I think it's really important that all the work not be done at this level, because in reality, I think everyone agrees that not much work could get done, but the technical work groups are controlled by the advisory panel. It was really envisioned that this would be a very broadly inclusive group that reflected all the most perspectives in this broad healthcare environment that we're in today. So, I think we're kind of in agreement in that. The advisory council was seated with some authority, and I think we want this group to continue to hold that.
So before we summarize, I think I think Chris was going to make
Just a quick question for Howard. You mentioned CMI wants to be involved in the stakeholder process in terms of meetings and developing the track 3. Did I hear that right?
So, more specifically, the discussions we had with CMI was that we would begin to look at the advanced payment models within this program to see, what would be best to meet the needs of the program overall, and anticipating that some of the pieces of the program would developing the track 3 or simplifying comprehensive primary care payments or other things would be important things to discuss, and that we would do that, the PMO together with CMMI would do that with input from the advisory council. I hear the advisory council saying the advisory council wants to do it with input from CMMI. That's the flip side of that. The important thing is that I think in order to make sure that whatever the product is that's developed is something that is achievable within the abilities of payment structure that CMMI can do. So to labor on a payment structure that that doesn't include input from the payer at this point seemed to be unwise. I think we agreed to that. So however it's, and I'm indifferent as to how it's configured, but I think all parties should be involved.
Yeah, no, I thought you were saying something right. So thanks for clarification.
Yeah, and that's where I was a little confused, because I would think if we're going to break out into groups, that the definition of the charter of those groups would be very important, and I would think that this advisory council would have direct involvement and influence on that, but it sounds like there's also a need that the program office is going to have for work. So I don't know how the two intersect, but I would just caution that we just be very clear in the direction and the deliverables of work groups. Otherwise, it could take on life of their own.
Bill, and then
Sure. So I think the technical subgroup makes sense for input and making sure work actually gets done. I think CMMI will find a way to make their input known. It's not like anything we say here isn't going to get back to them. So I don't really see the need for a subgroup if the purpose of that is to coordinate the conversation with CMMI. But having people that can get into the nitty-gritty makes a lot of sense.
Yeah, so based on the last conversation, the last meeting and this meeting, I think my question is, we've identified 2 potential technical work groups. One would be for payment redesign that's tied into track 3, as well as the FQACs. as well as any other. But knowing that this is already being addressed, Howard, so that conversation with CMMI about FQHCs, if there are additional information from this group, how is that funneled through to you for that? And should we have a work group that kind of speaks to that versus another one that speaks to payment redesign for track 3? And how do we keep coming up with these different, I guess, key initiatives or topics to address and then form the work groups to address them?
So for Howard Wason, I think the FQHC piece is pretty much locked down. I think that
That was established before the work group, before this committee council met.
so the discussion that we're largely focusing on at the moment is more around looking at a work group on payment design, which would be looking at the track 2, looking at increased accountability, looking at a track 3. So that's the element I think we're thinking about. And if I hear the members correct, and you correct me if I'm wrong, is that a subgroup makes sense. It's that all stakeholders should be invited / represented, that you all represent, and to be more technical, as Bob noted, and that the subgroup is chaired by a coach, one of the co-chairs, or a designee of the co-chairs. I think that's what I hear you all saying, unless I missed something. Katie's affirming it, so I'm pretty sure she'd tell me if I got it wrong. Anyone on the phone?
So
No, I was going to say, is anybody on the phone that has a comment?
So I think we can move on unless there's anything, Dr. Reedman.
Not on the next agenda item, unless someone else has something to say. Okay, thank you. The next two items are really kind of one, we separated them out, but I have some comments on this, and I'm like really interested in the community feedback, but you know, I'm president of a 90 provider group, and so I have 90 physicians feeding back to me constantly about the group, and I practice full time, and I think the secretary actually touched on this morning this afternoon. It's a perfect lead into this agenda item. I think is that the physicians and the patients are frustrated at the clinical level of the administrative burden of the program, and I think it gets into what the real purpose of the program is in my mind and our group's mind, and I think the purpose of the program too was to improve patient care and cut down costs. But what we end up finding ourselves doing is doing lots and lots of data entry, reporting measures. My comment always that you know, the fact that my patient's blood pressure and diabetes is controlled doesn't mean that I address their heart failure. So I'm reporting certain measures that I look at as don't really have a lot to do necessarily with the patient's outcome. What I really should be reporting on or being held accountable for is improving their quality care and reducing the cost. So I'm really interested, and there's a couple of items here that are important. That we're doing a lot of paperwork, a lot of reporting, and I think simplifying the system, and if we can get to a point where we're not staring at the computer constantly. And I personally make a real effort at that, not to stare at the computer and try to talk to my patients, but it gets real difficult. The computer's becoming between us and our patients. We really should be concentrated on their health care and their total outcome. So I'm really curious as the committee's comment about what we should be measuring and what's the best way to measure that, because I think that's one of the things that the committee should be addressing.
So you'll note that Alana, our colleague to the right, will be keying in feedback, so you all get to see what's being mentioned. And we'll bring this back to you all at a later date. But it's structured more in terms of benefits, barriers, and opportunities. So as you think about your responses, if you can begin to think about them from those dimensions, that'll help us in quantifying them and allowing deeper analysis post the meeting.
Bob, you put your part up first.
Well, I did it up first earlier, and other people just decided to talk. But anyway, thank you for acknowledging my following protocol. So at the last meeting, I vocal on this point about, you know, how do we know if this program is effective, and you know, the basic conversation, there were responses both at the table and afterwards. It's from CMMI's point of view, you know, it's also its effectiveness at what level. you're thinking about is, you, Dr. Reedman, you may be thinking about effectiveness at the practice level. I'm probably thinking, I'm sympathetic to that, absolutely. I'm also thinking about it at the macro level because, it's being, from the federal government's perspective, this is an adjunct to our total cost of care model, and there are major financial consequences, almost all of which fall upon hospitals under the terms of our contract. And so, and what I learned was that CMMI doesn't really have any interest in distinctively evaluating the effectiveness of this program from what they see as the totality of the Maryland program. That obviously concerns me because, this program is distinct. It is adding the costs of the care management fees, as everyone knows, are being debited against the total cost of care targets, and they're not trivial. So I do think we need to have measurements on ROI, and I fear, I know, having worked with academic researchers for many years, when you've got so many interventions going on simultaneously, it's impossible to really break out the effects of one versus the others. And we deliberately, whether like it or not, we have not created a randomized controlled trial here where we're doing the experiment in one place and not in another. So I think we need to come up with a measurement regime, even if it's looking at the performance more closer to the ground level, and whether whether processes and impacts are being felt, including what you might call the adverse impacts of is the paperwork worth the candle, so to speak, and other things like that. But it is really important that we build in a measurement monitoring and kind of a decision-making process as well. I'm also feeling maybe a little sensitive to this. Last week, CMMI posted the final evaluation report of the all-payer model. It's 278 pages long, not counting appendices of uncounted length. And they really dive deep and on criteria that had nothing to do with what we were accountable for under the contract. So, but that evaluation could be very consequential. And if we go through another period where we get a major evaluation done, which will be done under the new model, without some kind of clarity on how MDPCP performs as a program distinct from the rest, we're going to regret it. We're all going to regret it, I think.
And you got a comment?
So I just, Katie and Howard and my best answers. I did think that the MDPCP program was going to be subject to a evaluation as a separate subpart of the overall model. But am I incorrect on that?
Yeah, I'll let Chris answer, but yes.
Yeah, we've heard from the vets that the way they've structured the evaluation is not just the whole total cost of care model, but it's looking at the individual programs as well. So that would include MDPCP, care design programs.
That's not my understanding from somebody who used to work at CMMI, who's at this table.
Guess that means B. Is that okay? So I would guess based on the all-payer model evaluations, they look at what does the care redesign program look like, what does the all-payer model look like. But if you're talking about what outcomes do you care about and do you try to measure, CMS has in the past cared about total cost of care, hospital utilization, quality of care, et cetera, and how do you separate out the effect of a global budget from a primary care practice in the state of Maryland on the reduction in the hospitalization? It's impossible to attribute the reduction in a hospitalization to one or the other. And so my guess is that when they evaluate, whatever separate portion of MDPCP they can, they're going to pick measures that they think are sort of sensible process measures and not try to separate out the effect of a global budget versus primary care practice, because without randomization, how can you do that? And so I think there are sort of dangers on all sides, right? I mean, there's, look at the total cost of care model. You know, you fail to meet the savings targets, the state, I think, sinks or swims together. On the other hand, you know, if we don't have measures on primary care practices, you know, to Bob's point, in the all-payer model, there's a evaluation how we did at reducing smoking rates and obesity, right, which is not something that we targeted with any of our quality improvement programs. And so if we don't have sort of a theory for how do we think about the primary care program being successful or not, they're just going to make it up. And we're going to be very surprised by the answer.
So currently, the measures that are in the program are measures of, as you pointed out, like diabetes and hypertension control. They're measures of, well, yes, there was also the use of Asperger screening for mental illness. There is the CAPS reports, which is patient satisfaction. There is utilization, which is both ED and hospital utilization using HEDIS data so that it's observed versus expected. So there's a measure of how practices are doing. The overarching measure of that is that practices, in order to stay in the program, to your good point, need to achieve a certain level of achievement for utilization, for the CAP scores, for their quality measures, as well as a number of process measures, things like following up patients in their transitions from hospital or ED or nursing homes. So a certain number of percentage need to be followed up. They need to use do care alerts, ENS, use CRISP. They need to meet all of the care transformation requirements. If they do not do that, then they're forced out of the program. So they're given a runway to do that, but that's the measure. So one measure will be how many practices were able to achieve advanced primary care using a fairly high bar for utilization, for process measures, for clinical outcomes with quality, and patient satisfaction. So that's the extent, those measures are the extent that are available now. Additionally, the practices for the investments are held accountable to a budget where they are prescribed certain things, adding staff, doing education, certain things that are within the confines of what can be done with those budget dollars, the care management fees, and they're held to federal audits for those. So that's the kind of that's the current level of measure and accountability. I think it's been an interesting discussion. I don't know, again, that anybody has come up with what the right measure is for whether a program is ultimately successful.
Well, I just to respond, I think those are helpful measures, and some of them sound very specific to what goes on in primary care. When you get into utilization measures, it's a little harder to say whether those successes or failures were attributable to the practices versus other causes. Because we certainly say that hospitals are doing everything they can to reach out to people so that they don't end up in the ED, et cetera. And I'm not saying one deserves more credit than the other. It's just that they're overlapping. And so it's hard to isolate the effect. I think, that's a good starter set of measures. And I think that it behooves us to both decide what we can do within the state, to establish a measurement regime that we're comfortable with, and also to sell to CMMI a measurement regime that we believe is appropriate. In a past life, when I used to work with Dr. Johnson, we were a federal contractor. We did evaluation studies, and we came up with our own hypotheses, and CMS would approve them, and they had nothing to do with. They were not influenced by the subject of the demonstration, and but those were more academic kinds of demonstrations. This is like real life for all of Maryland, so you need to be able to influence how CMMI evaluates the whole program.
But just as a reminder to this group, last month, I think, if she's still on the line, she brought up an interesting point. point from her experience at CBC Plus. And the question that was still being kicked around is the state is making an investment in primary care and realizes that investment, you don't expect a return on that investment by the individual practices, rather it's a bigger system savings, or whether there should be individual ways to measure practices or the program success. I think, why don't we let her say a few words about that as a reminder for some of you, if she's still there. Maya, are you still there? She's on, so maybe you're muted.
Sorry, I was muted. I'm still here. I'm happy to repeat some of it, but the broader point is just there are. I think it's I guess a query about what it means to level set on the goals of the program, of the primary care program within the context of the global budget. There are lots of reasons to give PCP practices infrastructure dollars and then stand back and watch them perform. One of them is that you want individual practices to perform better on specific tasks. Another might be that you want practices individually and collectively to begin to change the care relationships with other parts of the delivery system. And then I think a third layer, and these are not mutually exclusive, they're additive. The third layer is that those changes in primary care produce a change in clinical culture, including in what expectations patients and beneficiaries have for their own care patterns, that then result in a more efficient system as a whole over time. I think the over time component is important. These are not, if you're looking for systemic changes and cultural changes, they don't happen in a year or 2 or 3, but they also don't happen by half measures. And that's where I think, maybe I wasn't particularly articulate about this at the last meeting, but there is nobody knows what the right level of investment in primary care is. But as loose benchmark, other OECD countries spend 30 cents on the healthcare dollar in primary care. We spend roughly 6 or 7. And there are all kinds of downstream implications because of those decisions. For example, when you talk about metrics, or when you talk about the interactions between the global model and the primary care model, the questions that come to my mind are things like, should we be looking at measures that reflect referral management, right? And whether PCPs have the wherewithal and enough of the infrastructure dollars to make smart decisions about which proceduralists they refer to, which imaging centers or infusion centers they refer to. And so I don't know if I'm being articulate enough about it now even, but if you make some investment, but not enough investment for them to really dramatically change how care patterns occur and the decisions that get made, then I don't think we should be surprised that we're not seeing the systemic huge impact, especially within a year or 2. So I feel like there is a danger zone. I don't know how wide that danger zone is between giving no investment and investment that's not quite enough, and then too much investment. I worry that we're somewhere in the muddy middle there, and that's partly because we haven't maybe had the explicit conversation about precisely what we think needs to be done in primary care to dramatically change the system. Because I don't think checking hemoglobin A1C is it.
Thank you very much. I'll get a comment on that. I think Scott had a comment first.
He was up before.
I just had a quick question, and I don't remember where I read this, but I thought maybe it was in the participation agreement or somewhere else. There was a suggestion of the Lewin Group being involved in evaluation or something like that. And so I think they made it. I think I remember the first time reading that, wondering that maybe I didn't know how involved that would be, and I don't think there's been much subsequent discussion, and I'm not complaining about that. I was just wondering whether that was anticipated to be a part of what the program-specific evaluation would look like.
Bill, do you want to have any comment you can make? I was just fidgeting.
So I think that the participation agreement says that there could be an evaluation done by CMMI or their contractors. I don't know that there's been any specification about what that is or what it might be. There's a larger evaluation done by Mathematica of the entire program. That's
Fluid may have been the learning contractor.
Blue Group was named somewhere because I very specifically read their name because we've worked with them before. So I don't know. I think it was in the participation. Maybe the one from last year.
Blue is currently involved both in multiple ways in the contract, both in terms of the learning system and other aspects of contracting with CMMI.
So they're withdrawing the learning.
So just funny coincidence, but that's where I used to work. And, although 15 years ago, so no residual loyalties. Thinking about what Dr. Pham said, you know, I understand we may not be able to evaluate, let's say, cost savings of MDPCP as distinct from the total model, but there are impacts we ought to be able to evaluate that are a little closer to the ground in terms of impact of primary care. Maybe it's not A1C levels, but there are things that we, you know, it doesn't take great creative minds to look at the literature and see how programs like this have been evaluated and can be evaluated, and to then hold it up against what's going on in the state of Maryland. You know, I unfortunately, when we talk about, you know, whether a program, you know, giving a program at least 3 to 5 years, maybe. I know Dr. Pham didn't say that, but she said definitely not within 1 or 2 years. But CMMI is all, you know, they are already, we're 9 months into the current contract. They're already, you know, they've already got us under the hot lights. And we can't just say, well, these programs take time, and so we're going to go ahead and invest $100 million a year in this program without finding some way to scrutinize it.
So my follow-up question to that would be, is that what the advisory council here can start having that dialogue with CMMI and say, are you open to considering, you know, when you start counting, I guess, our, you know, performance, right? Instead of feeling that we're already 6-9 months in and, you know, we're already on the fire. Is that a negotiation point?
So
Based on what,
I don't think it's a point of negotiation.
Actually, it's going to be a recommendation from the council. The council could say, here are some of the measures we think CMMI ought to consider. I think you heard Dr. Reedman talk about some of the challenges and the need for simplification, but we're hearing others talk about the need for some reporting. The question becomes, what would we propose to report? And that could be included in a report to the secretary that could be passed along to CMMI.
So will this be a technical working group to help develop that recommendation?
I was starting to say something about a work group. I thought, well, maybe no one will bring that up, but I think that is indeed the need here.
One thing I'd like to, this is Dr. Reedman's comment, is that we should be find specific ways, if there are those ways, to be skillful and precise in evaluating the value of this or any other program. But we also need to be very mindful as we do that at the ground level for primary care providers, their plate is very full. We don't want to add more things to that plate, but we want to be very intentional about taking things off of that plate, unnecessary reporting, things that don't add to the ultimate evaluation or the understanding or to anything, because this is I believe it's an important program, but it will only survive if we can make the lives of those who are actually implementing the program somewhat better along the way. So we just have to be very cautious about willy-nilly adding things to this without taking
I
Disproportionate.
totally agree. I totally agree. I think good evaluation would be one that does not add reporting burden or other burden to those who are performing tasks. And one of the criteria for success ought to be that it actually has made their lives easier in caring for their patients.
I have to comment on that too. I think that's exactly my point. I think that I've been practicing now for 31 years. And I think I've done a good job at building successful practice. I love my patients. I think they like me. But I ask every one of them about their smoking. I give them a hard time about their smoking every visit. But the fact that I have to make 3 or 4 clicks on a computer to prove that I talked to them about that so I can report it interferes. And that's my concern. Is that I think the bottom line should be that I'm improving patient care, cutting down on the ER visits. I'm following up when they leave the hospital. We've gotten aggressive about our TCMs, all of that. But that's where we should be measured, but not the fact that I didn't click 3 buttons or I was concerned because they told me that they were upset because their father died yesterday, and I forgot to click the button that said that they don't smoke, and now I didn't get quality measures for that button. That's the kind of stuff that I think we absolutely need to take off the plate. So,
So I think I yielded once.
Okay, go ahead.
So I also wanted to kind of push back a little bit in that probably some of the chaos of being in a PCP practice is that the Care First still has its measures, the MCOs have their measures, and other payers have their measures. So when you combine this, it is a complicated data cloud that's being gathered at primary care practices. We should keep this better payer alignment on the table as part of this group's obligation to it's not directly related to, it's not directly measurement, but the chaos of measurement adds to the difficulty of reporting anything. I think that the question of what are you reporting too much, or are you reporting things that are meaningless is also a distinction that I'm not sure I necessarily have gotten clarity on. I think that's important. The fire hose of EHRs are also, we can't address that directly, but whose fault is it that it's 3 clicks on your electronic health record to get that in there? It's not necessarily the programs, but what leverage do we have? And lastly, I think continually focus on what CRISP is providing is really important. I get lost on the dashboards, but I don't use it every day. And are we providing the right? There's a lot of valuable information on that, but I question whether a busy physician or a busy staff person can get that much out of the dashboards unless we really invest in the appropriate amount of training to make that happen. I would note that there's Chris does follow the approach to documentation, but I think we need to be sure that as these tools come out, there's appropriate education on how to use them. Otherwise, it's just noise.
Ben, to that point, we're very sensitive to that, and we've done a large number of, with each of the tools, large number of webinars. We have our coaches in the field who do hands-on instruction for the practices. We've done a series of staff training academies specifically around the tools, and most recently a provider leadership academy, which was all about leading with the data. So we'll continue to do that because it's a very good point. We appreciate it.
I was just going to suggest that we continue to leverage claims data for all of the reporting that we can, because quite honestly, we shouldn't be creating additional administrative burden. Almost all of the data can be communicated via claims, including CPT2 codes now. So I'm not sure why we would be creating a separate infrastructure for that. CG CAPS is already done for many, many patients in many, many practices. That's a standard industry set that's already being done. And there's measurements that are a subset of that we could pull from. It feels like perhaps we aren't simplifying things enough.
I agree. The fact that I
Pull it on
have
claims.
the fact that I have to report that the A1C was X when you paid for it and it was done. But the fact that I have to report that it was done, that's where some of the disconnect is. But it's the same thing, you are
Oh,
paying,
yeah.
you're paying for those A1Cs, you know they were done, and yet we still have to report that as a group and all. And it's time because we have full-time people in my group, and we're fortunate we have, we have enough providers and a large enough administrative office that we do a lot of this. But I don't know how you do it.
But you already did it and you already evaluated
Yeah.
it. You already know what range it falls in, and the office staff can just put that on a CPT 2 code and submit it with the claim.
But that takes time to do CP2. It takes extra time to do that for every time.
It does.
Or you could just send a lab file, right? And we got the results too.
I want to echo the point a couple of people have made about trying not to increase the reporting burden and the measurement. That's something that we hear from all of our groups. And as I think about this programmatically, one thing I wanted to mention, I think it's come up in a couple of comments, is the CPC Plus program was multi-payer to all payer in regions. And I would consider one of the measures of success of this program becoming as close to all payer as possible. And so I wonder, as we think about that and we think about measures of success and how through this stakeholder group and others we get there, I wonder if we can just be mindful of what that looks like and how we collaborate around trying to get there.
Well, I think, Dr. Riemann, that's going to be on our January's agenda to discuss is engaging in what approaches we can take, what policy recommendations we might make to engage more of a multi-payer involvement in this program. And I think Dr. Behrens, any comments you can weigh in on this discussion?
Well, I'm a major contrarian about the role of measurement. I don't think we're getting our money's worth with small efforts that we can measure stuff. And so I'm very sympathetic to trying to simplify. My focus, if I were Fed, would be to focus on unacceptable quality rather than trying to distinguish amongst acceptable, good, great. I don't think it's doable. Now, that doesn't help you right now. You have to be fine about, I think the policy community is getting crazy with this measurement stuff. We need to adopt processes that actually are shown to get better outcomes and try to hold practices accountable for adopting those practices and being less worried about the hemoglobin A1C. And that's what I'd be working to. I guess my other comment as I was listening to this is that I think it's a heroic assumption that you can sort of redesign primary care and have immediate savings on the total cost of care. There probably is a few things that primary care can do to reduce hospitalizations, which is, well, the hospitals are also trying to do that. That is a major payoff. But what Mai was talking about, who I've worked with extensively over the years, is a real cultural change that I think is much too ambitious to think you're going to accomplish that in 3 years when this is being evaluated. So those are some, I mean, I'm just getting oriented, but those were my initial thoughts.
So is it you're thinking that it should be more of an investment in the long term, and that early on you're saying that it really isn't a good way to measure its, if you will, cost savings or cost benefits, but at the same time look at unacceptable quality. But I would be interested in getting your reaction on what we heard Station talking about with claims. What is your thoughts around how claims can feed in the assessment of performance?
Well, on your first point, I mean, CMS is going to make some judgments. That's what Bob was emphasizing. And so you have to play to those requirements. And so what you might want to do for primary care redesign and what you need to do to achieve the savings that CMS is going to be looking for in hitting their quality metrics are probably two different things. And so you have to have a short-term strategy, and then ideally have to, be forward-looking in terms of real restructuring with the cultural change. One of my questions, by the way, I was going to ask Ben when the meeting ended, is what are you guys doing about the specialists? Because a lot of the excess spending is with the specialists. I have some ideas there. Your second.
We'll talk to you later about that.
Well, yeah. What was your second?
So the value of claims.
Oh, claims. ideally, the claims data produce a lot of the data for what you need for sort of straightforward boilerplate HEDIS measures. I don't think, ideally, you wouldn't have a separate reporting system.
And I think Kathy had a bit for next.
No, I was just going to echo what you two gentlemen said about the impact on primary care. I feel a little bit like a midget in a room full of intellectual giants in the healthcare arena for Maryland, just a little nurse practitioner from the boonies. But I will say that the impact of the burden for doing this has been tremendous. Our EMR does next to no reports. I knew nothing about spreadsheets. I wasn't taught my healthcare, training. So we have worked to do that. The reports that we have to submit are done manually for 3,000 people. Someone adds to and takes away every week. There's a lot of hoops that you have to jump through for that. And that is a lot, and it does interfere a bit. And like you say, you forget to click that I talked with them, and oops, that didn't count. I when we applied to be part of this program, I really loved the concept, and we are working to implement some of those things to make healthcare changes. We're looking at maybe implementing the Medicare program for obesity, looking at doing additional training, organized training, becoming a diabetic approved site through Medicare. So we're looking at ways to do that and improve those outcomes, but then but you still have that burden of paperwork and reporting. And in some ways, it makes it very difficult for the small practice.
I was going to say one other thing about claims effectiveness. One of the values of CPC Plus, rather than pure capitation, which I practiced under 30 years ago, is that you continue a claims flow. When you're just doing encounter data under capitation, you don't get very valid data. Or when you're getting paid, you get decent. So that's, I think there's a number of reasons why it's a nice hybrid of fee for service, a reduced fee for service, and a care management fee, which we used to call capitation. But one of the advantages is that you have the claims that should be able to generate the basic performance metrics that you're interested in.
I just feel it necessary because it's come up at least 4 times now to speak to multi-payer alignment and what some of the practical realities are for payers who operate in multiple market segments. The reality is Medicare Advantage and Medicare fee-for-service are not measured on quality in the same way. And you cannot be successful in Medicare Advantage without effective star rating programs. And star ratings come out of clinical quality measures for a fairly large subset of the measures, most of which come out of primary care. We can't change that. It's a fact. Medicaid has its own quality infrastructure that impacts payment. The FEP has its own set of quality metrics that impact payment. NCQA compares you to every other commercial carrier, every other Medicare carrier, every other Medicaid carrier. That's just what the playing field is. And so while I hear the desire, and we've worked really hard to harmonize in any way that we can across all of those programs so that we get down to sort of a core set of quality metrics about diabetes, comprehensive diabetes care, about that's why those are happening. But I just want to be careful that we don't set up an expectation amongst this council that we are ever going to be able to get all the payers to identically align, because they can't. Their business models will not support that, because that is not how they are paid. And those are the rules of the road. So I think to the extent we can make recommendations about harmonization, I think everybody wants that. The worst thing when people are rowing boats is to have everybody row in their own thing, right? All you do is spin around in the middle of the lake. You don't actually go anywhere. And so we actually think that there is real value in getting to sort of a core set of measures, but it can't just be what Medicare fee-for-service is, because it will not speak to the rest of the millions and millions of people that we serve. Does that make sense?
Station, and that, as this original program, first 5 years of this was conceived, and stakeholders gathered, and primary care and other stakeholders gathered, the one thing that was clear, was a request from everyone, was what you said is impossible to do. I think we've begun to make inroads towards saying that we can limit and align the reporting requirements. So I would say that I understand where you are now, but I don't believe that that's the end point. If we accept that we'll never be able to align these requirements, the reporting requirements and quality requirements, I think that would be a nihilistic approach to what we're doing. So things will have to change, but we need to be intentional and continue to drive that change. That's what we're doing here now. So we hope that we can.
I think it is
participate in that.
unlikely that CMS is going to change the Medicare Star Ratings program, under which they evaluate the relative performance of every Medicare Advantage plan in the country. They're just not going to change that because Maryland asked them to. So do I think that Maryland could use only a subset of those measures so that whether you were in fee-for-service or Medicare Advantage, it was some of the exact same measures? Sure, I think there's lots of ways to harmonize that. I just don't know that people always have a lot of clarity or even visibility to some of the other long poles in the tent that we have.
Just to add to that, I think, oh, sorry, go ahead.
Just want to close out on evaluation. A lot of the discussion on evaluation was like assuming that there's that somebody, whether it's I or some other person who desires evaluation, has a particular expectation of exactly what will be evaluated. Okay, because there were a lot of the comments were like, well, we can't do this, we can't do that. Well, use claims data because it's there. Okay, and we had a comment from Kathy that said, I'm just, we all exist to make sure your life. I view my job to make it so that you can be successful, not the other way around. Okay, and so one way, we should have a discussion. What would be outcomes that we would say, what we would agree are desirable outcomes that we can measure without increasing burden. One of the desirable outcomes, if you look at the RTI evaluation report on the model, they interviewed the hospitals, and one of the success factors was, did hospitals feel that they could successfully do this? Okay, did it make their lives more miserable, less miserable, things like that? That's a legitimate factor in an evaluation. We should be thinking of that. I'm not looking for, the holy grail of evaluation, but if we fail to do something that says we were accountable to ourselves for what we did, that would be a huge loss.
One last comment.
Yeah, I just wanted to build on what you said and before that, Stacia. Yes, I think that's why it's good that we're looking at this from the provider's perspective, Kathy, because they are the ones who are responding to all the multiple payers. So to the extent that we first of all agree, as Maya and others have said, there has to be some culture change. And if we believe that advanced primary care starts with team-based structure that's focused on care coordination, we do agree on something. And that's a starting point that informs either outcomes we're measuring or how these multiple payers can come together, because they want the results, right? They want the same outcomes to be positive, so they have to figure out, okay, how do we work closely with and partner with the providers to get that done? And that is a culture change that is based on evidence-based primary care, advanced primary care.
So I think on this particular topic matter, we want to carry your ideas forward into the next discussion. One might say, well, we need a work group on that, but I think it's a bit premature. I think we need more guidance from the group in order to figure out what the strategy of an additional work group might look like or focus on. So we'll carry this one piece of it forward into the next meeting. And for some of you who have been very quiet in this meeting, we'll look to pull out more thoughts from you as we move forward. So it's an equal exchange of ideas because you represent stakeholders that are very important. And we don't want to skip over those stakeholders by dominating the conversation by a small number of them. So, Dr. Reed.
And so, in wrapping up, just want to, all the agenda items, you can read the ones that we're thinking about for future meetings, but I like what David just said about, what I'd also like to double back to the agenda item we had from last time and summarize some of our thoughts from that too at our next meeting, so we can move forward. We're talking about doing one on January 29th. The calendars, we'll send out a questionnaire about that also, but like from the schedule for the room and the schedules for the two of us, that somewhere around January 29th would be the best meeting. So I have to thank everybody for coming. I think I told a couple people on the committee before that I have an interest in these valedictorian class of chairman of the economic department of Harvard right now, and just being of the MBA program at Harvard. And he and I were talking about when I was asked this on this committee. I was trying to make a decision because I have 2 other full-time jobs and I need a third. And he had a great comment to me. He said he has an algorithm he uses for all the things he gets asked to do. He said, first of all, did I want to do it? And I said, well, I'm not sure that's the case. And then the second one is, if you don't want to do it, it wouldn't be fun. I said, well, I'm not sure that would be the case. The third one was, would it have an impact? And that's the one that made me decide to do this. But I actually think that after a couple of meetings, I've really appreciated it. It's actually been fun to have the conversations here. So I think I'm meeting that second criteria. I'm not sure I'll be the first one ever, but I am meeting the second criteria. So I thank everybody for coming and for your input. And go from there. Questions? All right, thank you.
Have a good evening.
Thank you.